Good morning, everyone. It's 10 a.m. and we're going to get started with the London Public Health Forum. I'd like to welcome you to this month's edition of the London Public Health Forum. And the topic that we'll be discussing today is building health equity, tackling racism and ethnic inequalities in London. Now, I'm Kevin Fenton. I'm the Regional Public Health Director for London, based between the Department of Health and Social Care and the NHS in London. And I'm also the Statutory Health Advisor for the Mayor of London, Sadiq Khan, and I'll be chairing our session today. I know that many of you are both passionate about and committed to tackling health inequalities. We have seen the importance of looking critically at health inequalities, not only because of the persistent and pervasive nature of health inequalities that we're experiencing here in the UK and in London, but more recently, as we've gone through our experience of the COVID-19 pandemic and the aftermath of recovery, and in the wake of the devastation caused by the pandemic and the widening of those inequalities, I know that all of you on this call are committed to understanding the nature of those inequalities and what we might do differently about them. COVID also shone a light on the role of structural racism on creating and accelerating both the nature of the inequalities which you observe and how it complicates the prevention, treatment, and care responses as well. Where people feel that they're experiencing structural racism and discrimination, they're less likely to trust or have confidence in healthcare services. It can have a negative impact on the quality of care that they receive, a negative impact on their involvement in research trials, vaccination trials, and a negative impact in the outcomes that they experience as a result of engaging with health and care systems. For that reason, in London, we have been deliberate, focused, strategic, and pragmatic in our work to confront structural racism, to both name it, to think about the evidence that underpins its effect in London, to think about strategic approaches for responding to structural racism within the health and care system, and ensuring that as leaders working in the health and care system in London, we are committed to being visible, accountable, and to have specific programs on tackling structural racism and its impact on health inequalities. So I'm really pleased today that we're able to bring together leading presenters, scientists, programmatic practitioners, directors of public health, and colleagues working in this space to reflect on both what we know about the impact of structural racism on health outcomes and to share with you some pragmatic experiences of what's being done in the city to address this. For today's call, I'm also pleased to welcome a wider group of colleagues to our usual Public Health Forum. We have extended the invite for today's meeting to all of our public health colleagues working nationally, and we've also extended our invitation to our NHS London colleagues. So welcome to those of you who are joining us in the forum for the first time. We're so pleased to have you here. So let's go through the agenda for the meeting today, and then what we'll do is jump straight into the presentations. Following my introduction, next slide, please. The first thing I have to do is just to remind you of the housekeeping. And as always, if you could remain mute unless you're speaking, we're going to ask colleagues to turn your camera off while we're having the presentations. We have a large number of colleagues on the call today, and just to protect the bandwidth, if you could keep your cameras off while we're doing the presentations, but do keep them on when we're having the discussions and question and answers. We really love when these forums are engaging and questions are being asked and are being answered in the chat. So I'm going to encourage you all to use the chat function. If you have questions, I'll be scanning the chat function. I'll be asking those questions to our speakers this morning. We're recording this webinar because we know that for all of our Public Health Forum events, colleagues are not able to make it, and there's a strong interest in participating in the discussions and learning about what we discussed. So if you don't want to be recorded, please keep your camera off. Otherwise, just to let you know that we'll be recording the session as well. Remember to turn your live captions off. I know that a number of the topics that we may be discussing today may be challenging to us because of our own personal experiences. So we want to recognize that, and there are resources at the end of the pack that we've circulated for participants if you need help with anything that has been raised today. Next slide, please. So finally, just to run you through the agenda for today, we'll be hearing, first of all, from our keynote address from Professor Sir Michael Marmot. Following that, we'll have 20 minutes to have a conversation with Michael about the importance of his report, the research that he's doing on this issue, and having a broader issue about Sir Michael and his leadership in public health. Then we'll have a panel discussion with reflections from colleagues who I'll introduce later on in the session. And then finally, we'll wrap this up with a question and answer session and involvement from all of you in terms of questions that you may have. So finally, just to briefly introduce Professor Sir Michael Marmot. He's been the Professor of Epidemiology at UCL since 1985, and he's Director of the UCL Institute of Health Equity. He's the author of Health Gap, The Challenge of an Unequal World, published in 2015, and Status Syndrome, published in 2004. He's a distinguished visiting professor at the Chinese University of Hong Kong, the co-director of the CUHK Institute of Health Equity, and he's the recipient of the WHO Global Hero Award. Michael has been a great colleague and friend for many, many years. I've known him since my days at UCL, and he's been such a stalwart and strong partner in public health and tackling health inequalities. And I'm so pleased to welcome you here today. Michael, with no further ado, over to you. We look forward to hearing from you.
Thank you, Kevin. And it's a great pleasure to do this. And indeed, I was delighted when we were invited, excuse me, to do this review of structural racism, ethnicity, and health inequalities in London. When I chaired the PAHO Commission on Equity and Health Inequalities in the Americas, and we finished our report, I presented it to the PAHO Governing Council just before the pandemic. And I also made a presentation to the National Institute of Minority Health and Disabilities in the US, NIH. And the director said to me, "You've changed. I heard you lecture 10 years ago in San Francisco." And I thought to myself, that's unfair. Fancy remembering what I said 10 years ago. Completely unfair. But he said, 10 years ago, you said, we don't need separately to function on ethnic differences because most of the ethnic differences in health can be summed up by social and economic inequalities. And he said, you've changed. You're now saying we need to deal with structural racism as well. And indeed, I have changed. And part of it has come from this review that London invited us to do. I haven't changed in my commitment to social justice, but social justice requires we take urgent action on the evils of racism, not only, as I've been arguing, on the evils of avoidable social and economic inequalities. Let me just start with some of the health differences that we identified in the report. Maternal mortality rates, Chinese, white, mixed ethnic group, Asian, Black. And one of the clear messages from our report is that you may have good reasons for using a blanket term like Black, Asian, minority ethnic groups. We don't find that very helpful because there are big differences among ethnic groups, and those differences are really important. It may be that racism applies to any group other than the dominant white group, and so there's some reason for lumping different groups together. But as you'll see, the variation among different groups is important. So there's maternal mortality rates extremely high among people classified as Black. And where we can, we didn't use terms like Black. We looked at Caribbean, African, and the like. As you can see here, infant mortality rates, white British and Indian, Bangladeshi, Pakistani, Black Caribbean, Black African, any other Black background. What should the rate be? Well, maybe all infant deaths. That's why should any group have higher than 3 per 1,000 live births? Common mental disorder, interestingly, not much difference among males, the different groups, but big differences among females, white other, white British, Asian, mixed other, Black. And detention under the Mental Health Act, white, Asian or Asian British, mixed other ethnic group, Black or Black British. And with something like this, of course, there are at least two things going on. One is differences in the rate of mental illness, but the second is how that's treated by authorities. Crude rate for those aged under 18 supported through NHS-funded mental health. Asian, white, Black, other, and mixed. And again, we've got both things going on, the true rate of illness and how that illness is treated in the system. So when we think about how racism can impact on health, we think of at least three different ways. Racism. Repeated exposure to racism experience leads to worse physical and mental health. The second is what I had been arguing a decade ago, is that racism manifests itself in ethnic inequalities in the social determinants of health, in poverty, housing, employment, pay, careers, and the like. And the third is how racism impacts on services, child health, mental health services, the criminal justice system. All three are operating. Racism, direct impact of racism impacting on the social determinants of health, and racism impacting on experience of services. Percent of Londoners who reported being treated unfairly. Ethnicity looms large as a reason in people's perception for being treated unfairly. Sex, age, social class, religion, disability, sexual orientation. Ethnicity looms large. Now, this report was for London. Some of the data are national because that's how the data are collected. But where the data are for London, we would like to think they have general applicability beyond London to the rest of the UK, and indeed beyond the UK to other countries. So when we think about exposure to the social determinants of health, let me go back to my 8 Marmot principles. Give every child the best start in life, and education, employment and working conditions, having enough money to live on, healthy and sustainable places and communities, and taking a social determinants approach to prevention. We've now added tackle racism, discrimination, and their outcomes, and pursue environmental sustainability and health equity together. So, percent of children living in low-income households after housing costs. Chinese, white, Indian, and for a lot of the social determinants we look at, Chinese, Indian, and white look well off compared to many other groups, other Black, other Asian, Pakistani, Bangladeshi. So dramatic differences in child poverty by ethnic group. And simply to say South Asian would miss Indian, Pakistani, Bangladeshi. Percent of pupils meeting expected standard of reading, writing, and mathematics at the end of Key Stage 2 by eligibility for free school meals, the dark one, and not known to be free school meal eligible. Look at Bangladeshi, for example, doing very well, and particularly those young people eligible for free school meals. And the ethnic differences are much bigger for the poorer kids, those eligible for free school meals. Look at white British. The white British kids eligible for free school meals, or Irish, are doing much worse than the Bangladeshi, Indian, Black African, Pakistani. If you had some kind of prejudice and said, well, certain ethnic groups are not able to perform, and I've had a Nobel Prize winner say that to me, then my response is, well, hang on a minute. The white British kids eligible for free school meals aren't doing very well at all. Nowhere near as well as the Bangladeshi or the Indian children. Huge ethnic differences. But among those not in poverty, you'd say the kids do well at school. They do well at school. Percent of pupils meeting expected standard reading, writing. London does better than England for Asian, mixed, white, other, for pretty well every group. And that's important too, because if you think that ethnicity, poverty are somehow destiny, why is London doing better? It's an important question. It may be related to the funding of education, which is higher per pupil in London. So having said that young people of different ethnicities are doing well in the school system, now look what happens with employment. This is the difference in the percent employed, ages 16 to 64. White, Gypsy or Irish traveller, Arab, Bangladeshi, Pakistani. So 0 is the white British. And huge differences in the percent employed. That's really interesting because we're saying that the different ethnic groups do well in education, but in fact, the discrimination kicks in dramatically in employment. Median pay per hour by ethnic group, Chinese, Indian, white British, illustrating what I said earlier. Bangladeshi, Pakistani, Black Caribbean, or other Black African. The discrimination kicks in strongly in work. And percent in poverty after housing costs, white, Indian, Chinese, Bangladeshi, Pakistani, Black. Socially isolated, white British, white other, mixed, Asian, Black. The data are reported for the groups because that's the way they were presented. Now is the time to wake up to the scale of inequality and remove the scourge of racism from our society and improve health for all. We've got marked ethnic inequalities in maternal and child health and mental illness. There's racism in the experience of the criminal justice system and healthcare services. These findings are well known. Urgent action is needed. That's the maternal mortality that I showed you before. Age standardized percent reporting they have a limiting illness. Chinese, Roma, other white, other Asian, Indian, white, British, Bangladeshi, Arab, Pakistani. Huge differences in self-reported limiting long-standing illness. Among our recommendations are that all employers pay the London living wage and eliminate inequalities in pay by ethnicity. I have to say, I spent a lot of my career in receipt of grants from the US National Institutes of Health. I think if I had a grant now from NIH, it may well be cancelled because I'm concerned about inequalities in pay by ethnicity. That seems to have been ruled out now, rolling the clock back in the United States by 100 years. Strengthen enforcement of legal requirements for non-disciplinary recruitment, support people doing work training, reports of racism to be investigated by independent bodies, not employers. And what I said before, we'd like to think that our recommendations, not just for London, but for the UK and globally. What I said when we launched the WHO Commission on Social Determinants of Health, social injustice is killing people on a grand scale. I think we need to have in mind not just killing people, but social injustice is damaging the lives of people on a grand scale. We see it in London by ethnicity, we see it in the UK, and we see it elsewhere. Thank you. I hate to tell
Wonderful.
them this.
Michael, thank you so much for getting us off to a great start this morning. And you've covered quite a bit in terms of broader aspects of health inequalities and why we're concerned, and then specifically how these disparities play out across different racial and ethnic groups with some key recommendations for attendees. I know you've stimulated lots of questions in the chat, and we have a few minutes now to discuss with you quite a few of those. So if colleagues have questions for Michael, please put them in the chat and I'll be sure to get through as many as I'm able to. But Michael, as always with these leadership forums, we take a time to the opportunity to speak to you as a leader. We know that you've had a very distinguished career, and in your own presentation, you've reflected on how your practice in public health research is changing over time. So my first question is, um, we know you and we know that side of you being an excellent researcher, but also an advocate and an activist for the population health and inequalities. Where did that activism come from? And how is it evolving over time? And do you think this is a good sort of journey for public health researchers and practitioners in time in terms of balancing your activism and your research? Let's start with that.
Well, there's a rumor going around that people get more conservative as they get older. And, well, things aren't like they used to be. The opposite has happened to me. I've got more engaged as I've got older. I remember sitting around faculty tables, lunch tables, saying, asking the question, should researchers be involved in the policy implications of their research? And these were things we would discuss. And there were distinguished professors of epidemiology who said, no, you shouldn't get involved in the policy. It biases you. And I understand that. But and I'm very wary about answering your question. The implication of your question is, what should public health people do? And I'm wary of answering the question of what should other people do. And I have no compunction in telling governments what they should do. I'm nervous about advising younger people. They might listen to me, and that would be a huge responsibility. I want governments to listen, but never mind younger people. What I did, which is not necessarily a model, is years, decades of research.
Mhm.
And because it was research into the public health, there was always behind it the question of how might the answers to my research question influence practice. I wasn't trying actively to influence practice, but there was that implied question. How might the answers to the research question I was asking change things? Then at some point, I thought, what if they took this seriously? And then I thought, well, maybe who's they? Maybe it should be we. And I think the real change point was when I chaired the WHO Commission on Social Determinants of Health. And as one colleague said to me, I've heard you lecture many times before, but that's the first time I've seen you wag your finger. And I started to wag my finger. And it was the WHO Commission, I think. It was realizing that the inequalities were so extreme and they were damaging health to such a great degree. And that made me look harder at my own country, at the UK. And you'll remember, Kevin, when we launched the WHO report, I drew attention to Glasgow. I said the health inequalities in Glasgow are of the same order of the health inequalities between a country like the UK and a country in sub-Saharan Africa. So we've got to make common cause between the inequalities at home and the inequalities we see more globally. And
So,
so the I ask myself these questions regularly. I say to myself, are you still thinking new thoughts, or are you just applying what you think you know? Doing this racism report, I was rattled the whole time, because I was in that, one way of describing it is uncomfortable, um, but that uncomfortable ground where which I welcomed, where my certainties were being rattled.
right.
I had to ask myself questions all the time. Have I got the right way of understanding this, of going about it, the right conceptualization? Um, and so that was really very important.
Okay.
And and keeping those two going at the same time is a challenge, a
Particularly.
spirit of inquiry
Mhm.
and a spirit of activism.
Yeah, no, absolutely. And, there are key things that I want you to pull out in your response, Michael. First, that your advocacy is based on evidence, which I think is critical for those of us working in public health. Second, that it evolves over time. We never ever stuck in one area. Third, and I think you've alluded to this, of the build, it's not an individual journey. You've built coalitions, whether with the WHO, with the Health Equity Network, which helps to build and create movements on that journey as well. And in that, you're able to amplify and magnify the voice. And I think those core principles are one of the things we wanted to pull out of this session today, because people think that addressing structural racism is both a wicked problem and a hard to address problem. So my second question is, as you've begun to name structural racism as a driver of health inequalities, have you received any pushback? How have you been able to frame it so that it is, I don't want to say acceptable, but it doesn't generate the defensive posture that it often does. I know many colleagues on the call today will say, we know that this is happening, but we find it difficult to raise it in our systems. So any words of reflection on framing and landing it and helping people to look at the data and get beyond some of their defensiveness. And then we'll move on to some other questions, if
Yeah,
that's...
excellent question. Let me start by answering a different question. I'll sound like a politician.
I know that trick, but go ahead.
But yeah, I think it's relevant. A few years ago, I was at a meeting in Bogota, in Colombia, and after my lecture, one of the commentators, and he'd warned me in advance he was going to do this, but after my lecture, he said, and he was screaming in Spanish, the problem is capitalism, and unless you smash capitalism, there's nothing you can do. Nothing, nothing, nothing. And he was screaming. And the chair turned to me when the man stopped screaming and said, "What do you think?" And I said, "Well, obviously, I don't quite agree, because if I agreed, I wouldn't have recommendations about improving early child development. I wouldn't have recommendations about spending more on education and improving working conditions. If I thought there was nothing you could do until you smashed capitalism, then I'd go home, because there's no point making these recommendations." Why, and I think it's relevant to your question, is because you could say there's nothing we can do until we get structural racism out of our society. There's nothing we can do. Go home, forget it. Well, I don't agree. I'd like to get structural racism out of our society, but we can improve preschool education. We can invest more in children. It would make a difference. We could invest more in education. The decline in education funding per pupil over the years from the years of austerity, the decline in funding was steeper in more deprived areas. Where do the Afro-Caribbean kids, the poor Bangladeshi kids live? In deprived areas. So improve the funding for education in those areas. So in other words, one answer to your question is there's a great deal we can do. And by making it tangible, it doesn't become impossible. Get rid of racism, get rid of capitalism, get rid of, it doesn't become this grand overarching, until you get rid of neoliberalism, there's nothing you can do. There's a great deal you can do. Then there's a different kind of argument with which you're very familiar, Kevin, because you, in a sense, wrote a riposte to the Commission on Racial and Ethnic Disparities, which is nothing to see here. Absolutely nothing to see here. And there, I think we've got more of an evidence-based riposte to that. And my riposte is usually evidence-based, to the extent that I can. If somebody is of a libertarian bent and says, "I don't care if poor people suffer, as long as what I define as freedom for me is protected." But then I'd quote Isaiah Berlin, that freedom for the wolves has often meant death to the sheep. Your freedom is actually killing other people. So I partly have an evidence-based response and partly an ethical, value-based response.
Yeah, and I think keeping that balance is critical. Um, uh, One of the ways I talk about raising these issues is the sort of, I call it the say it, see it, act on it framework, which is say it, name structural racism, and be sure that you're introducing the term and its impacts within your organization, within the work that you're doing, because it is in naming it that you make it real and you create the space for people to begin to be open to dealing with it. See it, see how it operates in your organization. Look at how structural racism is affecting commissioning intentions, the leadership decisions, policy decisions, and question whether or not we can do better by virtue of our understanding of structural racism, and then act on it, which is look at the evidence-based programs that we know work to tackle structural racism and think about how we can implement that within our organizations. And some of that, Michael, are around policies, programs, and so forth. So I think your report really helps with the say it and see it aspect of this in terms of how do we describe it and name it and how it's impacting. Now, when you did this research, I think one of the things, and working with you on it, was the lack of data points on measuring structural racism and the lived experience of it, and what we could do as researchers to improve that. Because, in a sense, you're
Yeah.
linking ethnicity with a variety of outcomes, but also we need to get to the core. I wondered if you wanted to reflect on the methodology in this work. I know a number of listeners are wanting to understand that. And what does the research field do moving forward to build on your work? Thanks.
Well, I'm going to, with your permission, recount a conversation you and I had, Kevin, and I won't embarrass you.
Okay.
Um,
There are
but
500 people on the line. Go ahead.
um, so a conversation you and I had, and I said, look, let me take the example of gender discrimination in pay, the gender difference in pay. That's been well studied. So if people say, well, women aren't as qualified as men, they don't do the work as well, there's a, and so on and so forth. That's all been studied. Economists can answer that question. No, it's not true. The pool of Harvard and Princeton graduates, there are as many women now as men, but for a given level of qualification, women are discriminated against compared to men. For women doing the same job with the same qualifications, women get lower pay than men. It's really been well studied. So most of the counter arguments, and it relates to your earlier question about the framing, you can say with women, with the gender inequality in pay, we know there's prejudice going on. Because it's been well studied. Now, one of the issues is childbearing, and women lose in that pay progression when they take time off and they don't catch up. But that's also discrimination. And then I said to you, look, we know this so well for gender, the gender pay differential. We don't know it so well for racism. It's harder to say that because we don't have the data, it's not been studied as well.
Exactly.
And you said to me, but people's experience of racism is also a valid, I don't think you used the word data point, but is also valid evidence that it may not have been studied in the way I've just described, but it's also valid evidence. And I really took that to heart. That people's experience, their lived experience, is highly relevant. I would still like a stronger numerical evidence base along the lines that I just described for the pay differential, the gender pay differential. So I'd still like a stronger evidence base, but I really took to heart the that lived experience is relevant evidence.
Yeah, and it's something that we know from, the work that and the research that I've done on HIV, where the power of the progress that we've made on tackling the HIV epidemic has been the combination of biomedical science, epidemiological science, the qualitative research, and the advocacy and the lived experiences of people living with or affected by HIV. And it's that, I think, the most powerful model that we see of where global activism and action takes place when you have that intersection. So understanding how we build better data of all forms in this work, I think, is key. And that's why I know we have a lot of NHS colleagues joining us, looking at the NHS data, the Workforce Race and Equity Standards, or RES data, provides a phenomenal data point in terms of the lived experiences of staff, bullying and harassment, experiences of discrimination, and the ability to cut the data by gender, their position within the organization, the grade within the organization, and by the actual organization itself. So we have tools that enable us to look at these data, and I'd like to encourage listeners to ensure that we're sweating the assets that we have in our organization so we can go further with this. Michael, we have time for two more questions. One is going to be on methodology again, and then the other, we're going to go back to leadership in terms of your hopes for this work and the next step. But the first question is on intersectionality. It's coming up quite a bit in the chat. Yes, it's important to look at the data cut by ethnicity. And I know you know this, but I just wanted you to go through it with the staff. But we know that there are intersections with race, economic status, race and gender, and ethnicity and gender, and even age. In your work, were you able to explore aspects of intersectionality, and how might we continue to advocate for this in our research? Thanks.
Well, the big problem is the relative lack of data. So we don't have what we'd like. But to give you just a couple of minor examples, I mentioned it as I was going through. The ethnic differences in mental illness are much bigger for women than for men. The disadvantage in terms of mental illness of belonging to certain ethnic groups is bigger for women than for men. If we didn't think about that gender difference, and that should then open a window for us. What's going on? Why are women who have particular ethnicity more likely to suffer from mental illness than men? I showed you as an example, which I hoped would get away from some simplistic prejudice, that poor white kids were doing worse than poor Bangladeshi or Pakistani kids. If you didn't take that into account, if you missed that, you could say, why are the Irish and white kids, white British kids, doing so poorly if they're eligible for free school meals? So that that's sort of a window into the intersectionality. Where we've got much less data is, for example, disability. If you're poor and Black and disabled, and maybe of a different sexual orientation, we just don't have those data. And all this is going on in the US as we speak. Rolling the clock back on the progress. But so those kinds of intersectionalities are vitally important.
Yeah. Thank you. So my final question, Michael, really is around the global geopolitical challenges that we're seeing now and how quickly we can see things roll back, whether it's a focus on diversity, equity, and inclusion, which I know for many leaders in the London health and care system believe is not an optional extra. It's necessary for the quality of care that we provide, the trust and confidence for communities, and ensuring that we leverage the best out of our staff because have such a diverse workforce. And it's the right thing to do. I think for your work in inequalities in general, as well as the work specifically on structural racism, what are global partners saying about how we don't go back in time, and how we can continue to focus on this work, especially where we may have funding bodies pulling back, or you may have more political challenges of operating in this space? Are there glimmers of hope as a researcher working in this space with your international colleagues, where you're seeing people say, actually, we need to continue this work and develop it further? Thanks.
Well, as I think you know, I always find grounds for hope. But last night, I was asked to write a little statement about my interactions with the WHO center in Kobe, in Japan.
Mhm.
Why am I talking about the Kobe Center? When we set up the WHO Commission on Social Determinants of Health, I've already told you I started wagging my finger, and we said social injustice is killing people on a grand scale. And we said when we finalized and launched the report, we wanted to create a social movement for health equity through action on social determinants of health. So I was the Kobe Center, the WHO Kobe Center. When we did the WHO Commission, we set up 9 knowledge networks. And the Kobe Center led on the knowledge network on urban settings. And I went back and looked at their report from 2007, 8, and looking at the more than 50 people who were involved in compiling that report. And I thought so many of the names I recognize because they became part of our social movement.
Mhm.
These were people who would come up to me years later and say, with a sense of pride, pleasure, affiliation, I was part of your knowledge network on urban settings, on employment, on early childhood. We created this global movement. It really happened. And when I look at the way the language of social determinants of health has spread, um, in the United States, you pick up an issue of JAMA, and they're likely to be one or more papers on social determinants of health.
Mhm.
Policymakers are talking that language. So, on the one hand, they're the threats we all know about. And I've moved in your direction, Kevin. I'm co chairing a global council on inequality, AIDS, and pandemics set up by UN AIDS.
Mhm.
And as you know, if the PEPFAR funding is not replaced, there will be 6 million extra deaths from HIV/AIDS over the next 5 years. This is a drama of a high order. And the idea that a couple of swashbuckling individuals can be responsible for killing 6 million people, HIV/AIDS, how can one be hopeful in the face of that?
Mhm.
On the other hand, there is UNAIDS saying we want focus on inequality and health equity.
Yeah.
That's why we've asked you to do this.
Exactly.
That's why we've got our health equity network with 6,000 members now of our health equity network. We've
Mhm.
got 50 Marmot places at a WHO meeting in Cardiff the week before last. The Welsh Cabinet Secretary for Health announced publicly at a WHO meeting Wales will become a Marmot nation.
Mm.
We're working with Scotland to do a national strategy for Scotland, 3 Marmot places in Scotland.
Mhm.
I'm saying to England, come on, come on, we've got Wales, we've got Scotland. I'm talking to Northern Ireland. So I think it's taking off. And when I talk about health equity, as I said at the very beginning of my presentation, it was in the past always about socioeconomic differences. Now it's about socioeconomic and ethnic differences. It's
Mhm.
about social justice more broadly, um,
Fantastic.
socioeconomic racism, uh, tackling structural racism. And
Fantastic.
I'm hopeful. I'm hopeful. The fact that there are 494 people on this seminar by itself, I like numbers.
Yeah.
That's a number that makes me hopeful.
Well, I think we're making a history today. This is the largest number of attendees we've had. But in fairness, we've also extended the invite to our colleagues in the NHS and national public health colleagues working in OHID as well, because we thought that our experience in London, the research that we were able to commission, and huge thanks to our colleagues working in the Greater London Authority, Vicky Hobart, the Public Health Director there, and her team for commissioning this work and for supporting this work. This has been a critical part of our journey in London as part of the London's Health Inequalities strategy. So, Michael, thanks. It's been great to have some quality time with you and 500 people to hear your reflections on the work, the man behind the work, and the issues and context within which this work is taking place. Because for all of us working in public health and in healthcare, context really matters because when it changes, it can influence what we're able to prioritize, what we're able to do. But I think what you've highlighted here is the importance of staying focused on the evidence, building those coalitions, being strategic in your action, holding yourselves to account, and ensuring that you continue to move forwards. That's the most, I think, the important thing. Always move forwards. So with that, we're going to now move to three respondents who will be talking about how they're moving forward in their respective areas. The first respondent is Dr. Sandra Husbands, and Sandra is the Director of Public Health for City of London and the London Borough of Hackney. And before coming to East London, she was the Executive DPH at Swansea Bay University Health Board in Wales. Sandra is a fantastic colleague. She's devoted to unleashing the power of individuals and communities to improve their own health and well-being and building social capital for health. Sandra, we're so glad you're here this morning. Over to you.
Thanks very much, Kevin, and thanks very much, Sir Michael, for those fantastic insights and for the really beautifully framed and evidence-based report on structural racism as a determinant of health in London, which does have, I think, wider implications nationally and internationally. I think it's really important that we've put the evidence together in this way, because it's one of those issues that people have often misunderstood or overlooked because the evidence didn't seem to be there or the data didn't seem to be there. And you're right, there are still more data that are required. I mean, not just around things like the ethnicity pay gap. And it's one of the things that has driven the programme that we are working on in London, through the Association of Directors of Public Health in London, which has the rather long-winded title of Public Health Tackling Racism and Inequality. But the reason being that that tells you exactly what we're trying to do, but also makes it really clear that what we're trying to do is do it from a public health perspective, starting at looking at and understanding and defining the problem, gathering the evidence, defining our interventions, and then evaluating their outcomes. And this grew out of the inequalities that we were really that were highlighted by the COVID pandemic and the reports from Public Health England that demonstrated the data, but also the Beyond the Data report was really important, a key piece of evidence for us in driving our programme, so that we didn't resort to the typical public health pre-COVID approach of saying, well, there are these inequalities, but it's either mostly about cultural differences or social class differences. But to really understand, well, what is actually driving those social differences in health and what's underlying it, and then just enable some of us who've been experiencing that discomfort of talking about or experiencing racism our whole lives, we're able to actually start talking about it. And it's been something that's created some discomfort for other people. But actually, I think that as one of our, as someone said at one of our network meetings recently, we need to spread the discomfort in order to be able to move forward. So I was also quite, I thought it was very, very brave of Sir Michael to admit his discomfort in working on the report, and I'm glad that he said it. And I also just want to say I share your discomfort, but we all share the discomfort. That's how people grow and how we will all grow as a system. So our programme has essentially 5 themes that when we looked at what are some of the things that we need in order to be able to move forward in our sort of public health approach, better data so that we can really understand the problem, as we've heard just now. So one of our work streams is on improving ethnicity data, not just the collection of it, but the understanding of it and the granularity of it. Trust and cohesion, that grew out of the issues that we saw with people from various different communities and ethnic groups not engaging with COVID measures because they didn't trust the messengers. And we've been working on that and beginning to understand, well, there's a reason that they didn't trust the messengers. And actually, do we need to develop more trust, or do we need to become more trustworthy as a system? Another one is around working with communities and co-producing solutions. Another is around improving our own, putting our own house in order and working on how do we develop our workforce, develop anti-racist practice in our workforce, and also start diversifying our workforce. And that's the broader workforce. This is, I guess, complementary to what's happening at a national level with the Faculty of Public Health, with the specialist workforce. And then the last one, where we've yet to make much movement, but where the IHE report really plays into what we need to do, what we need to understand, and how we need to move is around the role of public health in social and economic policy, so that we can start to take that public health approach that has been applied to other areas like serious violence or drugs and say, what do we need to do to take that public health approach to improve social and economic conditions and start to dismantle the impacts of structural racism, and at a wider level start to undermine those policies and structures that are perpetuating it. So I don't think I'm going to say anything else. I think I'm going to stop there, Kevin. I'm not sure if I've had my 5 minutes.
You have had, Sandra, and thank you so much. One of the issues with the Public Health Forum is getting cutting edge insights from people who are practicing and doing research in the field and linking that with policy discussions. But we want to make these conversations real. And that's why we wanted to hear from you, Sandra, in terms of what can public health teams do? What are the directors of public health doing to convert this insight that we've had, as you say, from the pandemic, from Sir Michael's work, into tangible actions? And Sandra, I know that there are networks which have been created to begin to build capacity in this space. I wondered if you wanted to say anything more on that, and whether, especially for those working in public health teams, how they can keep connected on this.
Yeah, so well, we have a whole pan-London network that through this programme that enables people to come together. And actually Adiola, who's one of the 490 people on the call there, from Adiola Adebe from Newham, is the chair and convener of the network. And it meets, I think, once a quarter, and we have various topics of discussion that it's about bringing people together, whether they're actually involved directly in delivering any of the work streams or not, but who are interested in understanding what does it mean to take an anti-racist approach to my public health practice. And so they can focus on lots of different things. So the most recent one where a colleague, and I apologise for not remembering her name, I just remember it was Claire, said that thing about feeling uncomfortable and having to spread the discomfort. What was interesting about that was a white woman who'd started to do anti-racist work, and she'd found that she was sort of, going off and doing courses in secret and not telling her colleagues because she felt like everyone would be uncomfortable. And then she began to realize that she would never be able to change anything unless she was able to engage people. Mm-hmm. And so she just started being open about it, and she was uncomfortable to begin with, and other people were uncomfortable, but she realized that as you spread the discomfort, actually it decreases everybody's discomfort, but also it's through that initial discomfort to begin that people do start to change. Mm-hmm. And so even if as a first step, you could join our network. The information is if you're in a public health department in London, the information is on ADPH London website, and I think there's also a slide in the delegate pack that might have the web address in there, that a link to be able to join the network. And then if you're interested in getting more involved in any of the work streams, any of those 5 work streams, we would be delighted to have you as well. And you don't necessarily have to be directly working in a local public health team to be involved. And
great.
yeah, the thing is to just to like your framework, you see it, you say it, so you name it. We've named it. We've named structural racism as a determinant of health, and then we're saying, okay, we're going to be explicitly anti-racist now, and that means we need to think about what that means at every level of what we do.
Wonderful. All right. Thank you, Sandra, and thank you for sharing the details of how people can remain connected. And I'm pleased to say the chat is dynamic, and there are new teams and networks being made and colleagues offering to bring colleagues together on this issue. So my fire alarm is going on behind. I'm not sure, Sandra, if you can hear it. Good. All right. So we'll move on then to the second person today. I'm really pleased to have Habib Naqvi, who's the Chief Executive Officer of the NHS Race and Health Observatory, presenting today. Now, Habib works nationally and internationally to tackle ethnic inequalities in healthcare by facilitating research, making health policy recommendations, and enabling long-term transformational change. Habib joined the NHS in 2001 and spent several years working at the UK's Department of Health and Social Care, where he led national policy. And since 2013, he's been involved in developing and implementing national health equity programs. Habib, thank you so much for joining us this morning, and over to you.
Great, thank you so much, Kevin. And it's fantastic to be with you. As Kevin has highlighted, I've been working in the NHS and healthcare for nearly 25 years, and I see the NHS and our healthcare system as a fantastic institution. It's perhaps the most visible expression of a shared social contract between people, and we saw that so clearly through the pandemic years. But at the same time, to be proud of our system, our healthcare system, is not to be blind to some of the imperfections that exist, which Michael eloquently highlighted earlier. So yes, this is about closing the gaps in ethnic inequalities in health and healthcare. But there's a fundamental question which we and every one of us must answer, and that is, what kind of world do we want to live in? Because health inequalities are unjust, they're immoral, and they're wrong because they're largely avoidable. And that is the kind of the premise from which the NHS Race and Health Observatory was established officially in 2021. And it was on the back of a special edition of the British Medical Journal titled Racism in Medicine. And there was a very strong argument within that special edition of the BMJ to say that actually what we need is an independent body organization that can hold up a mirror to the rest of the healthcare system with regards to the inequalities that we see, the inequalities that Michael highlighted, the fact that Black women are up to 4 times more likely to die during childbirth, pregnancy, or soon after. It cannot be right today in 2025. The inequalities we see in mental health, in sickle cell disease, in cardiovascular disease, and the list goes on. And of course, throughout the pandemic, we saw the disproportionate impact of COVID-19 on our ethnic minority communities and health and care staff. So there is a level of urgency for us to focus on this agenda. And in a way, our country, our society, our healthcare system should be well equipped to deal with that level of urgency for various reasons. We've got a long history of migration in this country that goes back not just decades, but in fact centuries. We've always had relatively good legal frameworks in the Equality Act and the Health Inequalities Duties, and good investment in healthcare research. But I would argue that our collective responses to these wicked challenges of racial and ethnic inequalities in health and healthcare have been somewhat fragmented, costly, and sometimes very confused. And the responses to these challenges have focused largely on surface level solutions rather than looking at what in fact Michael calls the causes of the inequalities that we see. So what we've been doing within the observatory has been framing an operating model that's based upon three stages. Firstly, bringing together the evidence base where it exists, or establishing the evidence base where it doesn't exist. Secondly, turning that evidence into policy recommendations for change. And thirdly, supporting healthcare organizations and leaders to implement those changes on the ground. And it's fantastic, in fact, to have both Kevin and Michael on our board advising us and being very proactive, in fact, rolling up their sleeves and helping us with the work that we do. So there's probably a couple of things that I would like to kind of highlight before I hand back to yourself, Kevin. Firstly, the work that we've been doing over the last 4 years at the observatory has focused on the causes of the causes. And if I can give you just a couple of examples of that. The very first piece of work that we did was to look at the racial bias in pulse oximetry, the little devices, as you would know better than most people, that you put on the end of your fingers to test the level of oxygen in your blood. And this was during a pandemic that was obviously impacting the level of oxygen in people's bodies. And we knew from evidence, particularly from the US, that the darker the color of your skin, the less accurate these devices are likely to be. So we brought together the evidence base. We had very clear recommendations. In fact, we only had 4 recommendations for the major national bodies: the MHRA, which is a regulator for devices, NHS England, and for NIHR. And then thirdly, we began to support those organizations to make changes pretty quickly, because this was an emergency situation. And as a result of our work, we were able to work with NIHR to put out a call for further evidence, particularly from the UK, around this topic. The NHS England updated the guidance on the NHS Choices website very quickly with regards to home pulse oximeters, and the government announced an independent review looking at equity in medical devices. That's the level of focus that we need to have, and largely because we were able to focus on the data. And I know this point has been mentioned before, but I think it's really important that we focus on leadership. Yes, and that's really important. Looking at naming racism, as Kevin, you've highlighted, we focus on the level of accountability that we need at organizational and individual level on this agenda. We focus on engagement and partnership working, and critically, we focus on the data. And by focusing on the data, we do not get caught up in culture wars and wokeism, etc., but we highlight what the evidence tells us, the robust data, and that can be quantitative data, but also critically, it should also be qualitative data and lived experiences of people as well. And the final point, I guess, last week we published our new strategy for the next 2 years, which will focus on looking at some of the deep-seated, the deeply ingrained inequalities in health, continuing our focus on maternal health, mental health, sickle cell disease, genomics and precision medicine, but also focusing on some of the challenges that we see within the workplace. Because frankly, if we're in the business of tackling inequalities in health, which we are, then we need a workforce that's representative at all levels and fully supported and engaged. And so we will also be focusing upon looking at bullying and harassment within the NHS. That's our focus, and also looking at identifying the ethnicity pay and progression gap and producing interventions, resources, and support to close those gaps as well. So this is about leadership. It's about closing the gap between the promise of our ideals and the reality of our time. And in fact, what Michael highlighted, the statistics that Michael highlighted earlier, do reflect the reality of our time, unfortunately. And it's that demonstrable leadership that we need to take this agenda forward and to shift the dial of inequality once and for all. So I'll pause there, Kevin, and hand back to yourself.
Fantastic. Thank you very much, Habib. And thank you for all the work that the NHS Race and Health Observatory is doing in this space. As you said, it's a unique organization globally. And to have this as a organization that can shine the light, especially on how racism is manifesting itself in the health and care system, to base that work on evidence and to think about the implementation and impact pathway, right? So we're done characterizing racism and its effects, right? We can do more, but we can't stop there. And I think the Race and Health Observatory is saying, here's how you convert the evidence into meaningful action for impact. And it will require scale, it will require leadership commitment, and it will require accountability. So this work continues as well. Now, with that theme of moving from the specific to the general and enacting and achieving lasting change, I'd like to welcome our third and final respondent this morning, who is Jabir Butt, who is the Chief Executive of the Race Equality Foundation. Now, Jabir has gained an international reputation for groundbreaking work on racism and its impact on health and care inequalities, and he also uses evidence to deliver change in systems and the support available to individuals and their families from Black, Asian, and minoritized ethnic backgrounds. Now, his current work includes being co-investigator on an NIHR-funded randomized control trial of strengthening families, strengthening communities, a parenting program, as well as leading the development of the London Anti-Racism Collaboration for Health initiative. Jabir, welcome, and we look forward to hearing from you.
Thank you very much, Kevin. It's always a challenge being the last speaker of a session such as this, that perhaps I haven't got anything new to tell you all. But hopefully in the few minutes that I've got, I'll still be able to say some things that are of value. Can I start by firstly raising an issue about what is it that we mean by racism? I think a lack of clarity about racism has created a situation where we've become confused about our approach to addressing it, but also about understanding and analyzing it. So we see the disaggregation of data that demonstrates differing experiences as somehow being an opportunity to not lump people together. And we've lost sight of that fact that actually racism is a collective experience that actually impacts across communities. So there is still value in understanding that experience across communities and not just at a disaggregated level. It also means that some of the interventions that we've developed sometimes are not as effective as they should be. A clear example of that is that we've concluded that representation means employing more people of color rather than actually employing people with a different approach as well. It should be both. And if we don't do both, what we end up doing is replicating systems rather than challenging them. It also allows the persistence of a narrative that says race equity is somehow just targeted at particular communities, whereas what we know is that actually when we do it well, it impacts all communities. So, for example, continuity of care in maternity has been shown to improve outcomes for mothers and babies across communities. So that targeting of it that was in the NHS long-term plan at Black, Asian and minority ethnic communities was there about addressing inequality. But if we delivered it, we would have impacted all mothers who who were going through the system at the time. The second point is that we've got to ensure that we have the infrastructure to understand the impact of racism, but also whether the changes that we're implementing are making a difference. Some of you will know that we're actually carrying out a survey at the moment supported by the Joseph Rowntree Foundation, looking at some of the limitations about ethnicity data. But we're also quite clear that there is data out there that should be better used and should be used to try and understand what works and what impact it has. If I pick one example, we've seen infant mortality decline in the last 20 years or so. However, what the data has also demonstrated is that the gap between Black, Asian, and minority ethnic mothers and white mothers persists, and unfortunately, we've not seen the closing of that gap. But importantly, analysis has also shown that some of the interventions we put in place that have led to that decline in infant mortality, such as increasing breastfeeding amongst communities, actually will not make much of a difference to Black, Asian, and minority ethnic mothers, because breastfeeding is much higher amongst those groups than amongst their white counterparts. So we've got to look at other measures that are going to have an impact and consider those wider determinants if we're going to see an improvement. But that data is key to, and the analysis of it is important. A third point is that there are always examples of good practice, of excellent service, but too often it appears that these are driven by individuals or teams rather than the system as a whole changing. And a key part of something that Kevin's already mentioned, the London Anti-Racism Collaboration for Health, has been about trying to get systemic change to address structural racism. Many of you will have already been introduced to the Race Equity Maturity Index that we've developed as part of the large program. But what that really stands out is that it's trying to take a systems approach to understanding where we are now, developing an action plan to address racial inequality, and then measuring or not measuring whether we've made progress towards it. It's that systems approach that is really going to make a difference to addressing structural inequality. A final point from me is that we've heard a lot of talk about prevention once again with the new government, and prevention is key, because we will never be able to afford to treat our way out of ill health. There's just not enough resources to do that. But if we're going to ensure that prevention works with Black, Asian, and minority ethnic communities, we need to understand the key issues that they face. So, for example, we developed a program of community-based blood pressure monitoring for African Caribbean men. But in taking that program forward in a bus garage in East London, one of the things we discovered was that those men, if they had high blood pressure, would have to report it to their employer, and that would mean that they would be stopped from driving a bus. And it's a key source of employment for that group. So if we're going to take preventative measures, we need to understand the impact that they're going to have, but also how we address the possible outcomes of that. The final point is that a race equity lens is required in everything we do. The distribution of the COVID-19 vaccine was one demonstration of what happens when you don't apply that lens. So we distributed more vaccine to places like Surrey than we did to places like Lambeth, Lewisham, Tower Hamlets in the first couple of months. Why was that? Well, it was because we didn't apply a race equity lens, even though those communities were being disproportionately impacted. So hopefully we will all be working together to make sure that that's actually delivered. Thank you, Kevin.
Jabira, thank you so much. It's so important that we go from the specific to the general. The specific interventions which are tackling both individual racism, but as you've mentioned, systemic racism. Um, and as we view racism as a systemic construct with systemic impacts, thinking of our response more holistically and as a structural intervention becomes key. And part of that is, as as you said, how you bring coalitions, communities together to both define this, act on it, and hold each other to account. I'm excited about the London anti-racism collaboration on health, in part, Jabir, because I think it's really just creating a space to share best and promising practice across the city. Do you want to comment a little bit more on that? And you've been running for a year now, and the value that Larch is bringing to the London system. I wondered if you wanted to say a little bit more on that. Thanks.
Thank you, Kevin. Large is a collaboration across the system, so the GLA, the ADPH in London, NHS England in London, but have all come together to not only fund the work, but actually to work together in delivering it. So we've had a number of learning and engagement events that have focused on different aspects of improving health for London's Black, Asian, and minority ethnic communities. So we had an exploration around data. We had a really important exploration around community engagement, as we've heard a number of times already this morning. That trust is a key part of actually improving that experience. So community engagement plays a fundamental part. As importantly, and perhaps most successfully, the Race Equity Maturity Index has provided an opportunity for people to start thinking about a systemic approach to doing that, to addressing racial inequality. As is the case with most maturity indexes, it starts by actually getting an honest reflection of where we are currently in the work that we're doing, and then starting to think about what are the steps that we're going to take to actually address that. And you can find out more about that the REMI on the Larch website, and I'll share details about that in a second as well.
Wonderful. It'd be really good to share the Race Equity Maturity Index. It's innovative. It's come from the London system and it's being implemented in London, but the tool is available and can be used anywhere. It's an amazing opportunity for us to have a more structured approach to how we implement system change within organizations and systems. And Shabir, this is not only an issue for the health and care system. And we know in London, Metropolitan Police is looking at anti-racism, the fire services, London ambulances, TFLs. So my hope is that over time, that the energy that we have in the health and care system, working in partnership with other systems, can help us to improve our practice, improve outcomes, to create this movement on anti-racism as a critical part of serving Londoners better. And I'm hoping that for the colleagues who are not from London on this call, you'll also see our approach in the city and take heart that actually through dedicated, strategic, focused actions over time, you can make a difference. So we are at the end of this session today. As always, we go back to our keynote speaker to get any final reflections. I'm going to ask all of our panel members and our keynote speakers to keep your cameras on so we can see everybody before we close. Sir Michael, we have a couple of minutes for you, but any reflections on what you've heard from system partners on this issue, and then we'll pull the session to a close. You're on mute.
Enormously grateful to the panelists for their wonderful insights. Let me just pick up just a few things, not everything everyone said, but I'm really grateful to Sandra for acknowledging the discomfort for a whole variety of reasons, but partly it's an intellectual discomfort, partly it's emotional discomfort, but for a whole variety of reasons. But it's very important. We need to subject ourselves to this if we're going to move on and make change. And I agree completely with taking a public health approach to drugs, crime, and the like. Exactly. And I'm going to come back to Habib in a moment, so I'm not ignoring you, Habib. But what Jabir said, and I mentioned this briefly in passing, that while I made the point that the ethnic groups are different in a whole variety of different ways, but you can see the advantage of lumping groups together if we're looking at something like racism and discrimination, because it might apply to everyone who's not part of the mainstream. The mainstream, quote unquote, is now a minority in London. So that's no way to be. And the important point that, and it comes back to my hopefulness that Kevin, you and Jabir both made, and we put in our report the good examples of things that are going on in London. This is not all misery. There are examples of really good practice of making a difference. And combining what Habib said and what Jabir said, Habib said, and I agree entirely, this is about what kind of society we want. This is really fundamental. Having said that, we've got practical things you can do without tackling structural racism at its root cause. But we do have to attack it at its root cause. We can't just do the practical things. This is what kind of society we want. I've been arguing that if asked for one recommendation, it would be to put equity of health and well-being at the heart of all policy. And what Jabir reminds us is we should have a race equity lens to that as well, or as an integral part of putting equity of health and well-being at the heart of all policy. And then we will start to address Habib's question of what kind of society we want.
Wonderful. Michael, thank you so much for those very powerful closing comments. So colleagues, we're coming to the end of the session now, and the objectives of today's session of the London Public Health Forum were to bring public health leaders, practitioners, and teams from across London to really understand the health impact of ethnic disparities and structural racism and to identify potential solutions. We wanted to create a safe space for us to hear about these challenging issues and to hear from system leaders about the work that's being done. We wanted to have a space to think about how the public health community can work together. And I can see in the chat, you've been sharing resources, networks, links. So thank you so much, everybody, for being such an active and engaged audience. And we wanted to share best and promising practice as well. You know, when thinking about all of this, it's easy sometimes to be overwhelmed. And I'm going to end by just, again, projecting a few slides. The first takeaway for me is that what I hope you've seen today is we're arguing in London that meaningful change in tackling health inequalities and ethnic health disparities must now integrate structural racism as a core part of what we do. Why? Because when we know better, we must do better. And we now have the evidence, we now have the networks, we have the tools, we have the leadership commitment to do better. And that's why we wanted to have this focus today. I shared in the chat the framework that I use in thinking about what we can do as individuals in tackling structural racism. And I thought I'd end the session by just reinforcing this. We need to say it, name racism, say the entire word, because we must name a problem to get started on solutions. We ask each of you to see it, to ask questions within your organizations. Well, how is racism operating here in our HR systems, in our commissioning systems, in the policies and programs that we have? Whether you're working in a large or small setting, be brave to ask that question of your leaders and your colleagues and identify early targets for action and levers for intervention as well. So understand what are the routes that you may take to begin addressing this. Do you have a staff network? Do you have an equity lead? Do you have leaders that are visible in this space addressing this issue? And then finally, we're asking each of you at the end of this call today to act on it. You have the power to organize and to strategize, to act. And you also have individual power to do things differently, because we know not only is racism structural, but it's also individual as well. And how do we lead differently to address this? And finally, how do we use collective action to inform, support, and protect us all? Thank you, colleagues, for joining us today. It's been phenomenal seeing you all, and I am so pleased to have had the opportunity to, hopefully I'm stopping sharing, yeah, to have such a distinguished panel with us today. I hope you've enjoyed this episode of the London Public Health Forum, this session of the London Public Health Forum. Huge thanks to all of our speakers for being so engaged and so passionate. And thank you all, the largest group of attendees on a London Public Health Forum. And I'm so pleased that it's on this issue. Have a wonderful rest of the morning and all the very best.
Thank you very much. Thanks, Kevin.
Bye-bye.
Bye.